Which is the range of a standard antibiotic therapy duration?
So historically, we've learned that antibiotics for various infectious diseases can be given 7 days, 14 days, 21 days. And this historical practice comes from a very old practice. 300 AD, the Emperor Constantine issued a decree that there are 7 days in a week. And so we started in the 1940s to use antibiotics as units of Constantine, 1 unit 7 days, 2 units 14 days. But and the practice continued not based on evidence.
Which are the determinants of the antibiotic therapy duration?
Whenever we decide on antibiotic duration, we need to take into consideration several factors. The first are related to the patient, whether it's an immunosuppressed patient or immunocompetent patients. The others are related to the site of infection that we're treating. Is this a urinary infection, meningitis, or endocarditis? And the third depends on the drug we are using, how good it penetrates the site of infection, and the pharmacokinetic and pharmacodynamics considerations for the drug. I don't think the one rule should apply to all patients. There are many characteristics in a particular patient scenario that we need to take into account when we decide on the duration of therapy, how quickly the patient defervesced, etc., and the markers that show clinical improvement in response to antibiotics.
What is the importance of shortening antibiotic duration?
In an era where we are seeing an emergence of antimicrobial resistance worldwide, which is contributing to the poor outcome of the patients infected with drug-resistant pathogens, there is a lot of effort into antimicrobial stewardship. And one of the key elements of stewardship is to really try to shorten the duration of antibiotics in clinical scenario where prolonged therapy has not been found to be more effective than shorter duration of therapy.
Which are the consequences of too long?
Prolonged antibiotic therapy can lead to many negative points. Of course, emergence of antimicrobial resistance, poor compliance of the patient to adhere to the drug, but also there is an increased cost of therapy, increased collateral damage with a higher risk of Clostridium difficile colitis, for example, and delayed discharge of the hospital when we require a prolonged therapy for infectious diseases.
Which are the scientific evidence on that?
There are currently numerous well-designed randomized controlled trials in various infectious diseases that have assessed short duration of therapy compared to the standard longer duration of therapy, and have showed that there is no benefit from longer duration of therapy. The studies have been done in various indications, including some of the most common infectious diseases, such as community-acquired pneumonia, hospital-acquired pneumonias, cellulitis, urinary tract infection, as well as bacteremia studies. And very importantly, there are studies even in immunosuppressed patients, such as febrile neutropenia, where shorter duration of therapy was found to be associated with a similar outcome as the longer duration of therapy.